So today we're going to talk about the work we've been doing over the past couple of years, testing the feasibility of psilocybin-assisted therapy in patients who receive hospice care. It's a trial that's called the PATH trial. I think I have a beeper here. And so I'm the PI of this study. I'm also one of the study therapists. And Roxanne is one of the study therapists and a co-investigator. And we have a whole team also that we really want to acknowledge today. We'll have their names later. And none of this work would have been able to happen without the tremendous support we received from a number of philanthropic organizations and donors that I really, really want to express deep gratitude here. And I also want to thank the patients who had the courage to participate in this pilot trial while being at the very end of their lives, and their families who supported them in doing so. It's been really an incredible journey, working with these patients and families, and hopefully we can convey a little bit of that today through our presentation. And I let Roxy start us with a few clinical vignettes about some of these patients and how they came about in this study.
Yeah, thank you, Yvan. So as Yvan said, we want to start the presentation to center us in the patient experience. And I don't know how many in the audience have experience working with patients on hospice at the very, very end of life. As a psychiatrist, I didn't until my work in this study, and what I found and hope to convey to you here is that there is something distinct and important about where we find people when they're near the very end of life. So these three brief vignettes are patients that I was a co-therapist for in the PATH study, and I'm going to introduce them to you to give us a sense of the existential landscape patients are encountering on hospice. So Sam is a 47-year-old mother with interstitial lung disease and chronic rejection of her lung transplant. She feels isolated and that she, as she put it, won the shit lottery, both by getting a rare disease and then getting a rejection of a lung transplant she felt so lucky to get. Despite taking a proactive approach to her mental health, she has withdrawn from most family activities and spends more time alone in her room. The hospice team struggles to identify her existential needs. Peter is an 81-year-old widowed former probation officer who also has interstitial lung disease. Since his wife died 5 years ago, he feels his life has no purpose and he is waiting to die. Though he struggles to articulate his feelings, he does meet with the hospice chaplain regularly and identifies as Catholic. And finally, Amanda is a 48-year-old married attorney with uterine cancer. She continues to work almost full-time and is preoccupied with being a burden to her loving and devoted husband. She keeps the hospice team at arm's length. So hopefully that gives you a little bit of a sense of the complexity and the nuance that these patients are facing, and something that I think we can all probably relate to if we work in the field of serious illness care is that existing tools don't really get to the heart of the suffering. This quote is from an oncologist that was part of a qualitative study that Yvan and the team completed, eliciting the perspectives of serious illness care experts on the role of psychedelic-assisted therapies in this population. And I'll share his quote. "There's a huge gap which you face every day as an oncologist, which is trying to help patients cope with anxiety and stress that go along with having a cancer diagnosis and deal with their mortality. Really seeing that every day and yet having limited tools that really help them, whether it's referring to a social worker or a psychologist or antidepressants, you feel you don't really get to the heart of it. And it feels like psychedelic-assisted therapy has the potential to get to the heart of something that's really difficult for us to address." So how do we think of the heart of what that is? So we're going to tell you a little bit about demoralization as a background for the study. So demoralization is a construct that describes a sense of a loss of meaning, purpose, and powerlessness that is often seen in patients that encounter serious medical illness or other major life stressors. It is associated with, but independent from and distinct from depression and the other DSM constructs that we're frequently using in psychiatry. And I think that's a really important point to underline because It shows the effort that's being made to transcend the typical psychiatric constructs when we encounter patients that are having a suffering that is more nuanced near the end of life. Demoralization is of great clinical significance. It's highly prevalent in patients with serious medical illness, and it's also associated with a high physical and psychological symptom burden, including an increased risk of suicide. It is the strongest contributor for quality of life in patients with serious illness, and no pharmaceutical treatments exist for demoralization. There are existentially based psychotherapies that were developed for work with this population, but they have limited efficacy, and they also are quite demanding in terms of time and resources. Not to say psychedelics aren't, but there is also promising data that psilocybin-assisted therapies could help address demoralization. As we'll see here in the next slide, it's a brief survey of the studies that have been done in patients with serious illness since 2011. These studies have shown more diverse interventions and populations, and as also more rigorous methodologies. I think many of you are probably familiar with these studies, so we're not going to be going through them today, but the point I want to make here is that many of these studies were looking at primary outcomes of psychiatric constructs, such as depression and anxiety. Demoralization was often looked at as a secondary outcome and showed a lot of positive improvement, signaling that there is a potential for these treatments to effectively target demoralization. Another point we want to make is that patients that were treated in these studies, while they had advanced cancer, their advanced cancer was relatively stable. They were seen in the ambulatory setting, and this distinguishes them from the patients that we are going to present to you today who were receiving hospice care. And again, for those that are familiar, things can change very quickly when patients have advanced cancer, and the nature of the progression and the change is something that needs to be considered when thinking about whether psychedelics are feasible and effective. So in that vein, I think it's natural that there are questions about the clinical relevance and safety for these treatments in patients that have dynamic and progressive underlying medical processes. So this is a quote from the same study that I mentioned earlier from a psycho-oncologist. To me, it seems like a very risky treatment with relatively low benefit for a very small number of patients. And so there's a part of me that just sort of wonders about the whole enterprise of doing this kind of work. We had this very question in mind when we approached the PATH study. And I'll turn it over to Yvan to tell you more about that.
So working with terminally ill patients, it really came naturally for us to think about this trial. Oops, we lost the... To think about this study really in the context of where the whole person approach care that hospice provides happens. And to see if we can integrate psilocybin-assisted therapy into hospice care, so hospice care serves 1.4 million people each year in the US. It seems as the ideal setting to work and think about this integration because of the patient-centered care that is inherent to hospice care. Teams are composed from MDs, nurses, social workers, music therapists, chaplains, who work together to really follow patients' needs and see how they can best support symptom management, coping, decision-making, and really accompanying patients and families through the end of life. And we know that it's a place where, of course, people will have a heavy symptom burden and lots of medications to alleviate these. There is a heavy psychological symptom burden as well, and existential distress. And there is a short length of stay in hospice as well, because most people are referred pretty late to hospice care. So these were the constraints in which we had, and also the assets, to think about how do we integrate psychedelic-assisted therapy within that. So the central question was, it's a pilot study, so looking really at the feasibility is like, can we do this work? Can we recruit patients who are terminally ill? Can we treat them? Can we collect research outcomes to assess the safety and efficacy? So this is what I just mentioned. Our primary objective was around feasibility, and then secondary objectives as safety and efficacy. And so our primary efficacy outcome was demoralization, as we just introduced. We also measured more traditional psychological outcomes such as depression and anxiety, also spiritual well-being, pain, and physical symptoms, and how all these would respond to psilocybin. So the setting of this study, we collaborated with, so the study was a collaboration between Dana-Farber Cancer Institute and Care Dimensions, which is the largest hospice organization in Massachusetts. They serve about 5,500 patients every year, and most of them are cared for in their home. So they have 2 hospices facilities where the sickest patients, the more complex patients, can be admitted for more intensive care. But the rest of hospice care happens at people's home. And the patients who would be eligible for this study would receive care in their home. So they would be adults, they could have any terminal illness, and they had moderate to severe demoralization on the scale that we use, which is the demoralization scale number 2. You can see one of the hospice facility here, and this is where patients were dosed. So here's a photo of how it looks like in the winter. There are very nice patio that we could use during the nicer days with patients, and they could enjoy the outdoors. Right. And so this trial was designed as a mixed method study using quantitative and qualitative measures to assess outcomes. We interviewed, after the intervention, we interviewed patients, family caregivers, and hospice staff as much as possible. The end goal was 15 patients, knowing that our target for feasibility was to be able to treat 10 patients out of the 15 enrolled, knowing that some of them would drop out of the study because of their illness progression. We constituted our therapy team really also building on this interdisciplinarity that is so important in this patient population. So with palliative care clinicians, people from psychiatry and psychology, social worker, we had a music therapist. Initially, we had a chaplain in the team, but who moved in a different state. So we lost our chaplain, but worked a lot with the hospice chaplains who were taking care of the patients, which we're going to get back on. This was really helpful. And so the way the intervention was structured, it was 1 single dose of psilocybin, 25 milligram, and that was surrounded by 2 preparation sessions and 2 integration sessions. So the dosing was happening at the hospice facility. We had to have people transported to the hospice house, but all the rest of the sessions were happening at patient's home. So we could prepare and do integrations in patient's home, meet with the family. That proved really, really very helpful. Right. And I'll head back to you. Yeah.
So I'll tell you a little bit about our therapeutic approach. So, our therapeutic approach was mainly driven by the patient population that we were working with, and also the existing care structures and the philosophy of palliative care and hospice, which is primarily about centering the patient, paying very close attention to their relational systems, whether those are their loved ones that they lived with, their close friends, and also the members that are caring for them on the hospice team. And it's also existentially based, because a lot of the issues that the patients are having and where their distress kind of crystallizes is around big questions. Some of the existential paradoxes derived from Irvin Yalom's work were things that came up quite frequently for our patients. The paradox of life and death: how do I live while I die? Freedom versus responsibility, aloneness and connectedness, and meaning versus lack of meaning. Some themes that we found to emerge with our patients were that of connection, meaning, and transcendence. So this is really the kind of theoretical framework around which the therapy was built. Like many psychedelic studies, on the dosing day, we were really encouraging the patients to stay inwardly focused. The music program was a big part of the experience, and we were so lucky to have Lisa, our music therapist, be a member of the team and help us develop our thinking around music as the third therapist, providing a really strong, containing, comforting presence. And this was something patients shared with us afterwards. They really felt to be true. And the next 3 points really condensed around the idea that our close collaboration with the interdisciplinary hospice team, as well as the loved ones that cared for the patient, it was involved at every single step of delivery of the intervention, from enrollment to co-construction of the intention. Setting the intention for the dosing day was something we often encouraged the patient to come to themselves, and they did, but oftentimes we would need, to get a little bit of help and further background from people that know the patient better than we do, whether it's family or members of the IDT. And similarly, viewing the entire therapy as occurring within a multi-layered container which consisted of many different aspects: the hospice team, the study therapists, the space in which the intervention was delivered, the music program, and the patient themselves. And then, of course, working very diligently to do a close handoff to the hospice team so that once we met with the patient for the 2 integration sessions, the members of the hospice team that were closely involved in their care had a good sense of what it is we worked on and how they could continue to support the patient in their ongoing integration. And this was something that obviously depends on the patient, but something that I personally felt it would be really hard to walk away from the intervention not knowing that there were skilled clinicians who were with us and were going to carry on and continue the work. And finally, supervision. So this is something that in the world of psychotherapy is very important, and we built a supervision infrastructure for our team where we, as a therapist team, the 6 of us, would meet together as frequently as we could before and after important treatment sessions and discuss our experience with the patient, offer feedback, have a chance to talk about our feelings that we were having come up in regards to the patient we were working with. And this was really important for the health and integrity, I think, of the team as well as the intervention.
So some thoughts on feasibility, which is, again, our primary outcomes. And I'll stay at a broad level here because we're still analyzing all our data. So as I said, our objective was to recruit 15 patients, which took us about a little bit less than 2 years, 1.5 years to complete. I think our goal was to recruit 15 patients over a year. We needed 6 months more. And I think that tells something about how sick hospice patients are, really. And we had many, most of the patients we screened. And I think one of the particularities of this study is that it was not open to any volunteer who would volunteer for the study. We screened systematically all the hospice organization patients every week and identified those who might be eligible, and then discussed with the hospice team. And for patients who were eligible, we would send the information, and if they were interested, hear back from them to discuss this further. So that gives us a pretty good idea of who in hospice is eligible for this kind of treatment. And it's, of course, a minority of them. Most of them were excluded because they were too frail or too sick, just not enough functional to get out of their home. So one of the insights is like, could we do a better, might people access more easily this treatment if we could deliver it at home? Probably yes, to some extent, but also a lot of patients would be excluded because of cognitive disorders or just incapacity to consent or just being too frail and not even have bandwidth and energy to engage in such an intensive therapy. So I think we learned a lot about that, and yet we met our objective of being able to treat 10 patients successfully. And in these patients who were able to engage in the therapy, we've seen really very promising results. And so we'll be telling more about that. Just a word on the 5 patients that dropped out of the study. Did most of them, like 4 of them, because of illness progression. And one of them, after 2 preparation sessions, had a very deep discussion with their therapist and had shared with them things that she hadn't shared with anybody else. And that really provided a relief that made her feel much better and less demoralized. And then when she thought about it, she said, like, I don't want to take the risk to destabilize where I am now, and I feel I've opened up enough, and she wanted to continue on that. And so she decided not to do the dosing. Just a few words around also some of the learnings around the medical complexity. So it is possible to treat people with psilocybin-assisted therapy despite high medical complexity. It's not easy. It requires a lot of interdisciplinary work, as we mentioned. But we had to make a lot of decisions around symptom management and treatment, potential drug-drug interactions. Those people receive high doses of morphine or pain treatment. They may have treatments for their nausea, like cetrons that we don't really know if they interact with psilocybin. So we learned a lot. We had 2 patients who had more than 5 liters per minute of oxygen while being dosed. We were wondering if those patients have strong emotions during their sessions, how is this going to impact their breathing? And can we safely go there? So we've learned a lot around just medical safety and feasibility. And despite this, as I was saying, we had no psilocybin-related serious adverse event. 2 of our patients, so we had built in the protocol that patients could stay overnight at the hospice house. It was not a requirement, but so the default is that they would be discharged home the night of the dosing day. And 2 of them, we decided at the end of the day, because they were fatigued and they were feeling safer to stay, 2 of them stayed overnight. But that was not counted as a serious adverse event because they didn't change their hospice status. And then we had expected mild to moderate psilocybin adverse events. So even though we are not able yet to present our efficacy data, here are a few quotes, and I'll let Roxy read the quotes.
Okay, so the quotes are going to represent the viewpoints of a participant, a family member, and then a member of the hospice IDT. So we were hoping they'd come one at a time, but that's okay. First is Sam, the patient I mentioned, who is the mother dying of interstitial lung disease. And this is her describing what she experienced while on psilocybin. At one point, there was this stream, and everyone and everything in the universe was just kind of dipping in and out, dipping in and out. And it was kind of like, you know what? It's okay. I worked out a lot of grief and distress, and I am definitely more at peace with things. The next quote is written by a nurse in the chart describing how a patient had appeared to her differently after the psilocybin intervention. Graham expressed how his experience during the session provided him with the knowledge that he is strong enough to face himself and his mortality, vulnerable enough to feel the sadness of his losses, and alive enough to experience the joy still available to him in nature, music, and his relationships. So, nice thing to read in a note. And then this was a quote from Peter, the 81-year-old man's son. It made us close in tough moments. He's not one to openly share feelings on a regular basis. This really made him more comfortable at expressing things that we never knew about him. We felt closer to him, and he felt closer to us. And here are some follow-up vignettes to share with you how the 3 patients I introduced at the beginning of the talk evolved through the course of the intervention. So Sam sets an intention to connect with her heart center and has a powerful mystical experience on dosing day, referring to the stream I just quoted. Her experience of unity and confronting the biological fact of her illness allows her to work through grief and feel more connected to herself, her family, and the hospice team. Peter struggles to set an intention, ultimately settling on wanting to live, not just waiting to die. He has a difficult dosing day with frequent requests for morphine and a dysphoric vision with religious themes, which intensifies his sense of worthlessness. The hospice chaplain is called and offers an interpretation of his worth being in giving and receiving love and offers an anointing ritual. Peter's demoralization improves, and he describes feeling closer to God. He continues to make use of the anointing ritual with family and friends. And Amanda wants to reconnect with her sense of competence. She struggles to disconnect from her work and to allow the hospice nurse to care for her leaking ostomy during the dosing day, rather than her husband, who she wants. She processes her fears of dependency with the therapists and is able to choose rest and allow care as she declines during the integration phase. So my hope of what comes through sharing these vignettes is that nothing changes about the situation, but the patient's sense of connectedness to themselves, their significant others, and their hospice care teams allows them to have a bolstered sense of agency and less of a sense of powerlessness to move through what is ahead for them. And now back to Yvan. So
just rapidly, a few key takeaways that kind of sum up what we've been discussing here. So definitely it is feasible to integrate psilocybin-assisted therapy in the treatment of hospice patients who experience demoralization. It is demanding, it is a demanding intervention that really requires at every step to weigh the benefit-risk ratio and really the importance of ongoing consent, as we've seen with the patients who dropped out and who, I think one of the things we've learned a lot as well is how just opening the space of the perspective of a psychedelic experience allow people to dive deeper into their experience. And for many of them, it's already a big shift in how they relate to themselves and others. So just a few words on the vulnerability and the complexity of patients, and also the quantitative demoralization outcomes are to be, we're still working on these and they're being computed. But we've seen that people get really closer from themselves. They're able to slow down and to stay with their experience, explore a little bit deeper how they feel. And this helped them develop more sense of connectedness with themselves, others, and the hospice care team. So a sense of peace and acceptance that is being developed. And this is, I think, almost the last slide. So beyond the next step, so of course the next step after the PAF study is to do a larger study to confirm those results. And yet the regulation is changing in Massachusetts, and doing research in hospice patients is really complex because of how sick they are. And so we're hoping that this model, based on this model, we can also learn how to treat people as psilocybin and other psychedelics become more available in the community, and how to develop those models in the community. There are a number of other conditions that people with serious illness experience that we are exploring, including existential distress, pain, adjustment disorders, and depression. We are also working on different treatment modalities, different psychedelic drugs or individual group therapy, working with caregivers and having them almost done. And and really working on access problematic as well. So developing a training program that Roxy is leading, as well as implementing our learnings in the clinical setting using ketamine-assisted psychotherapy. We're hoping to be able to compare psychedelic drugs or see how they can work together as well, or who benefits from what. And ultimately to really have a clear roadmap about how we use these treatments in the standard of care in patients with serious illness. And so a big thank you to our teams, really dedicated in alleviating the suffering, and also not only about suffering, but promoting existential growth in patients and families. And we're all concerned by those problematics. So thank you for listening to us.
Thank you.